Welcome to another episode of Single Payer Radio. We broadcast our program from the historic Habern Building here in downtown Louisville. The show is a project of Kentuckians for Single Payer Healthcare, and we're an affiliate of the Kentucky chapter of Physicians for a National Health Program. We have this program because we believe healthcare is a human right. We advocate for a national, not-for-profit, single-payer healthcare system. Everybody in, nobody out. The views and opinions expressed on our show are those of the speakers and not the station. I'm Mark McKinley, a volunteer with the group. Single Payer Radio can be heard here on WFMP 106.5 on Mondays at 2 p.m., Tuesdays at 7 a.m., and Wednesdays at 11 a.m. If you can't pick up our signal, you can live stream us at forwardradio.org. You can also go to forwardradio.org/single-payer and listen to past programs. WFMP is an all-volunteer station. We rely on the community for your ideas and our funding. Join us, forwardradio.org. And we ask that you save the date. Join us to celebrate Medicare's 58th birthday with a documentary, a PBS documentary. It's called The Power to Heal. That will be Sunday, July the 30th at 2 p.m. It's a free showing. It's at our main branch library here at 3rd and York. And the documentary is based on David Barton Smith's amazing book, The Power to Heal: Civil Rights, Medicare, and the Struggle to Transform America's Healthcare System. And you could get a preview to that documentary by going to forwardradio.org. Kay Tillow interviewed David Barton Smith a couple weeks ago. And finally, big thanks to all the folks out at All People's Unitarian Congregation. Kentuckians for Single Payer Healthcare recently made a presentation there. The congregation was very welcoming and supportive. Jill Harmer led the presentation with assistance from Harriet Seiler. Great job, Jill and Harriet. And if your group would like representatives from our group to present information about what we do and why we do it, you can contact our chairperson. That's Kay Tillow. Her email address is nursenpo@aol.com. nursenpo@aol.com. We also own the copy of The Power to Heal, the documentary, and that's thanks to member Paul Hoppy. We'd be glad to show it to your group if you can't make it to our Medicare birthday celebration. We've got Doctors Mike Flynn and Jean Shively back in the studio. Mike.
Thank you, Mark. Let me begin. This is Michael Flynn, a retired surgical oncologist from the University of Louisville. Let me begin with the usual disclaimer that any comments I make during this program represent my personal views and do not represent the views of the University of Louisville or the Department of Surgery.
I have the same disclaimer. What I say are my sole opinions. They do not represent Taylor Regional Hospital nor the Department of Surgery at the University of Louisville.
Well, we're back again with our special guest, Judy Albert, which I will reintroduce again in just a moment. She was on with us about 2 weeks ago, talking about issues related to women's health care post-Roe versus Wade. There was so much to talk about and so much we didn't get to talk about. We've invited her back. She's back again today, gracefully willing to discuss these issues with us. She's a retired obstetrician gynecologist from Pennsylvania, went to medical school at the University of Cincinnati, residency at the University of Pittsburgh, fellowship in reproductive endocrinology and infertility at University of Pennsylvania. She was on the full-time faculty of both University of Pittsburgh and University of Pennsylvania for various short time periods, and then was in a private practice in Pittsburgh for many years in reproductive endocrinology, infertility, and in vitro fertilization services. Judy, welcome back. Thank you again for your willingness to come and talk about this important issue with us, or these important issues, because there's a lot of stuff here. As we have done in the past, we're going to give you an opportunity to make whatever comments you'd like to make for as long as you'd like to make them, and then the conversation will begin with Gene asking you whatever questions he'd like to start with. So, Judy, the floor is yours.
Thank you so much for asking me to return. I really enjoyed these conversations, and hope that your listeners will gain some insight as well into this important and really quite distressing problem. Very recently, I think the article that was released in JAMA.net came out on about July 3rd. And it was actually a summary of a report from the Center for Health Statistics out of the CDC, compiling statistics on maternal mortality. And perhaps unsurprisingly, continuing to show that our maternal mortality rates have outstripped other industrialized nations. We have the worst maternal mortality of all of the economically developed countries. And even worse, it's not improving, in spite of the fact that there's been a reasonably high level of attention paid to this, I would say, over the past 5 or 10 years. So the various study groups in the associations for obstetricians and gynecologists have come up with care plans and care mapping to try to target some of the preventable causes of maternal mortality, one of which is postpartum hemorrhage, and cardiovascular diseases are others, to try and get the word out so that these deaths can be prevented. But, always, because we have a very fragmented healthcare delivery system in this country, it's difficult these kinds of care map plans, especially in rural areas where hospitals are closing their labor and delivery units. People are having to travel very long distances, and meaning that their babies delivered far from home, and their postpartum recovery time is usually back at their home, away from a place that would have the knowledge, the wherewithal, the blood supply to respond to some of these emergencies. And the other thing that this report that came out and was picked up by a lot of the mainstream media was the widening gap in maternal mortality between racial groups, with Native Americans having the highest, Black women and Hispanic women somewhat lower. And still, it needs to be pointed out that a white woman in the United States has a higher chance of dying than that same white woman in Sweden. So I think that's a place to launch off from this in our discussion.
Judy, can you go into some of the reasons for the disease factors that cause maternal mortality?
Well, interestingly, one of the issues that comes up is, how we are measuring the time frame where a death is considered maternal mortality versus not related to pregnancy. And so that the Center for Health Statistics data use the WHO definition as death of a woman while pregnant or within 42 days of termination of pregnancy. And so those are much more acute situations generally, and would be in the category of the cardiovascular and hypertensive problems like preeclampsia, eclampsia, also hemorrhage, which is usually an intrapartum type of event. But if you look at the ranking of causes of death out to a longer period of time, it's been recommended that we consider deaths within a year of a birth to be considered as a maternal mortality. Actually, mental health issues were the number one cause, but that's when you expand the definition quite a bit.
I was surprised that the Indian Health Service has done such a poor job. This is a U.S. government sponsored program all over the Indian reservations in the West and Alaska, but they continue to have the highest perinatal mortality rate. Do you have any idea why that program is not working better?
I think it's so chronically underfunded that it's I don't have direct experience with the Indian Health Service, but I do know of some physicians who have worked on the reservations, and they have a very difficult time staffing their clinics. Talking about rural areas, that they are by definition in some of the most remote areas. And so, I think that's the main reason, is that there's been a lot of inattention to the plight of life on the reservation, the plight of people living on reservations, and their access to care crosses over from Indian Health Service into the non-Indian Health Service, and I believe that there are some issues with that. But again, I'm not an expert in that area. It's just so obvious that there's extreme underfunding, and that goes back to the beginning when Indigenous people were herded onto reservations.
Well, let's move this conversation just a little bit and talk about maternity deserts. And Judy, I'm going to ask both you and Jean, because these seem to be situations that are existing mostly in rural states, often in red states that have these restrictive anti-abortion laws, many of whom are based upon a misunderstanding of the biology of a pregnancy. And so maybe, Judy, we could let you start and just give us your thoughts about maternity deserts. And Jean, I'm going to ask you to do the same thing. Then I have some specific questions, about things like, is it going to get better or worse, and some other things like that. So Judy, if you could give us your thoughts about maternity deserts, and let's see where that takes us.
Sure. So, it's been documented well that rural hospital closures, maternity care is suffering because the cost of providing maternity care in rural areas is too high to allow for hospitals that are for profit to make it worth their while to provide those services. And sometimes these hospitals are converting into freestanding emergency departments, but that's not very helpful for the prenatal care that's so important. And certainly, an obstetrician gynecologist is not going to set up a practice in a place where they have no ability to do a delivery within, 150 miles or more. Some of these places in rural Georgia and Florida, people are crossing state lines over 300 miles to have their delivery. And, unless they have some novel programs where midwives and other practitioners are traveling and providing care within the rural community, and that is a project that's happening. These people are not going to be entering a care system that is capable of delivering the type of medical care that they need. So it's a huge problem. It's a huge staffing problem, and it's definitely contributing to higher rates of maternal and infant mortality in rural areas compared to some urban areas. But I would also like to point out that urban areas, even such as Pittsburgh, which is the home of a very large university medical complex that employs more than any other employer in our Western Pennsylvania area, they have closed maternity wards in all but there may be only one hospital that in our Allegheny County, local rural area that urban area that's still doing OB. So it's also a problem for people that live in areas where they may not be 300 miles away, but they don't have access in their own local community, and fighting through transportation issues in urban areas is also a problem.
Let me make a comment that I've made multiple times on this program before asking Gene to make his comments, that basically what we're looking at is the fundamental question, or the fundamental issue with healthcare in this country, is that we do not have a healthcare system that is focused on providing healthcare to our citizens. We have a healthcare industry that is focusing on extracting profit from almost every healthcare activity. Gene, you've been down in Campbellsville in rural Kentucky 35 or 40 years.
Actually, 45.
Okay. Well, what's your thoughts about the maternity deserts? And then I'm going to ask you both about whether it's going to get better or worse and why.
Well, I think the biggest problem is hospitals lose money on OB, about approximately, and it varies from one hospital to the next, but they get reimbursed about 70% of the cost. And most of the patients are Medicaid, 60 to 70, some hospitals probably up to 80%. And so if they don't get reimbursed enough to pay their expenses, they have to get that money from somewhere else, usually from departments like radiology and physical therapy make money. So if we could talk to the legislature into paying at least the cost of doing OB, I think that would make a big difference in Kentucky.
Now, are these not-for-profit hospitals?
Yeah, I'm talking about not-for-profit.
Well, now before you go on, I've been looking at some articles recently, and there's a number of questions that are being raised about whether not-for-profit hospitals and not-for-profit healthcare systems are actually, they're supposed to provide a certain amount of their care to people like that who can't afford it or don't have any insurance at all. And there seems to be more and more data out there that indicates that they're not doing that.
You mean not-for-profits?
Not-for-profits.
Yes.
And they have a tax status that allows them not to pay nearly as much. I don't know I'm not an accountant, so it's above my head. But the responsibility of providing care for citizens in a community is part of the not-for-profit tax status, which allows them not to have to pay as much taxes as they would if they weren't categorized like that. So, do you have any sense of where this balance is? Because it seems to me that more and more of these non-profit facilities and healthcare systems are not providing the care they're supposed to, and I think their tax status should be investigated.
Well, I can just tell you what's happened at our hospital. We're a hospital district, and all non-for-profit hospitals don't have to pay taxes, and we actually get have our own tax. You have to pay a property tax for the hospital, and the hospital I worked in, it's usually around $1 million. Sometimes it's more. And one of the neat things about that, if you're a patient there and you pay property taxes and you have some bills, you can actually get a discount. You can get reimbursed on that tax. Now, there are very few hospital districts left in the state of Kentucky. I actually don't know how many are left. I know that two of them, one of them essentially closed, and one of them has gone with another hospital system. And the number of non-for-profit hospitals in the state is really gone way down. I don't know the exact number. I can find it out. I should know that. But the number of independent for-profit non-for-profit hospitals are gone way down. Now, I'm familiar with two for-profit hospitals. One of them is only 20 miles from me, and they have an OB service, and it works very well. I don't know of them ever turning patients down. I can tell you that when I was in practice, we never turned patients down because of their insurance. And the hospital, to my knowledge, has never done that. They may transfer patients because they can't take care of them and they need to go to a tertiary care center. One of the largest and most profitable for-profit hospital is in Somerset, and their OB service, they have obstetricians that work like hospitalists, and they have an obstetrician on call 24/7. Of course, the patient who's about to deliver may not know that obstetrician. I don't particularly like that, but that's where they're running their service. If you have an obstetrician who had your prenatal care done, most of the time they'll come in and deliver you. It's my understanding that they're doing the same thing in Ashland, Kentucky. The other problem we're running into, though, is the attitude and the fortitude of physicians wanting to put in the huge amount of time to deliver babies. For example, in the probably the 60s, 70s, and 80s, there was a family doctor in Lebanon who would deliver more than 500 babies a year. And we had an obstetrician. The obstetrician who delivered both of my children. It was not unusual for him to deliver 500 babies a year. Now our hospital delivers maybe 200 or 250 a year. And we do have two obstetricians, but we just had to recruit one, and we're having a real problem with recruiting obstetricians. They don't want to come to a rural area and have to take call every other night, although we now have midwives, but they still, to be up all night and then have surgery scheduled the next day. It's just a very, very situation. It's a bad situation that causes a tremendous amount of work. In the past, physicians were willing to do that, but now we have very few physicians who want to do that kind of tremendous work.
Judy, so here, according to Gene, it's in Kentucky, it's bad, and it's going to get worse. What's your thoughts about what's going on in the rest of the country?
Oh, I think, everything that Gene said is is emblematic of other places. I mean, there definitely has been a move to start this OB hospitalist programs to make it more attractive and appealing to young trainees to go into that field. Because you're right, people just aren't willing to basically give their life to being on call all the time. And I think to a certain extent, the point with adding in midwives and nurse practitioners has been something that physicians in general, and certainly in OBGYN, have resisted. The advanced practitioner movements into the field to their detriment, because we need those people, and oftentimes they can provide more ability to relate to populations, and they may be community members who are committed to staying there. So I think that's an important thing as far as the workforce. But yeah, I mean, it's definitely changing. Even in a major urban place like I am, they have McGee Women's Hospitals, where I trained. It's a hospital that does typically about 10,000 deliveries a year and has a very large residency program. And they now routinely have hospitalists who are working 24/7, but they're not going off to practice in their office the next day after they delivered 5 babies. They're doing shift work. It's my understanding that this may not be terribly different from the way the NHS is in the UK. I don't have direct information about that, and I think it can be made to work. But the care system has to be much more integrated, so that when a person carrying a pregnancy enters the healthcare system, they're all going to get a consistent level of care, and that is something else that we're just missing, because, as we said and you pointed out, the fragmented system that we have right now, and the way that Medicaid covers pregnancy care is inconsistent, because every state can do their own thing as far as who's Medicare eligible, which pregnancy treatments and tests are eligible, how long they provide coverage for women postpartum. And Medicaid expansion states have expanded coverage, but it's inconsistent with the states that don't have a Medicaid expansion, so that coverage in the postpartum ends much earlier than it would if you were in a Medicaid expansion state. So, all of those things, how your health is when you start the pregnancy is going to be impacted by the coverage you had available to yourself to receive health care. And if you only become eligible for Medicaid because you were pregnant, which is a thing based on income levels and so forth, then you're not going into the pregnancy healthy. And if your postpartum care is not being extended past 3 months or whatever it is, 6 or 12 weeks, then your intrapartum time period, if another pregnancy occurs, is also not a time when you are receiving an adequate access to medical care. And all of those things are adding up to create this situation with maternal mortality.
All right, let's talk about this in light of the recent ideological wisdom decision of the Supreme Court to overrule Roe versus Wade.
Yeah.
So let's talk about Idaho. Now, Idaho is a rural state. It's my understanding, and if I'm not correct about this, either one of you don't hesitate to correct me, but it's my understanding, and also it has these anti-abortion laws, and I believe Idaho has the quote fetal heart unquote law, which we'll talk about in a moment. But the ratio of practicing physicians to the population in many of these states, specifically Idaho, are lower than in states that don't have these restrictive abortion laws, often by as much as half. And then you add to that the inability to practice medicine in an appropriate way, or practice obstetrics and gynecology in an appropriate way. And again, we talked about this a little bit last time. And Judy, if I'm not expressing this correctly, I would ask you to correct me on it. But with these quote fetal heart unquote laws, if there is an active fetal heart rate, or if there earlier in the pregnancy is some sort of ultrasound activity that is used in those laws to indicate a fetal heart in a cluster of cells that would become a fetal heart if the pregnancy lasted longer than 5 or 6 or 7 weeks. If you have a woman, either 6, 8, 10, 12, 14 weeks of pregnancy, who has a miscarriage and ruptures her membranes, and then is at risk to either bleeding or infection, sepsis, which could have life-threatening consequences, the appropriate treatment for that is to terminate the pregnancy. Is that not correct, Judy?
Yes, that is correct.
So this is a normal, appropriate medical practice under that set of circumstances. So if you have a state like Idaho, where that makes it, if an obstetrician were to conduct a pregnancy termination at, say, 10 weeks, whether there's a fetal heart or an ultrasound messaging indicating some of these activities, they're at risk of either financially being fined or actually possibly being jailed. So what happens to the future of the ability to practice in that situation? It would seem to me that people who are practicing there, who are not comfortable with those risks, would leave the state, and people graduating from the residency programs, the fellowship programs, are not likely to go into a state like that. Now, Judy, am I missing something here? Or can you help me out with this process? It seems to me it's not only bad, but it's going to get a lot worse unless something changes.
Right. Yeah, no, you're absolutely right. And the difficulty is that it's just not possible to legislate medical treatment, and there are so many nuances, as you both know, in the presentation of various disease states, and there are certain immutable facts that ectopic pregnancies kill people, and delayed care is going to result in deaths in some of these situations. It's difficult to know and get the statistics, as we talked before, because institutions and hospitals and so forth are effectively muzzling practitioners who want to speak out about this. So I think the biggest problem is the gray areas that are arising, so that practitioners are questioning their own judgment, thinking, what are we doing here? And of course, at the end of the day, and it's interesting because if you look at some of the pro-life literature and media reports, they really try to poo-poo this idea that, oh, treating ectopic pregnancies is going to be impacted in a negative way by these laws by saying, no, that's not the case. And it's said. And so, there's all kinds of just misinformation, terrible information. And it already is having an impact on the choices that graduating medical school individuals are making with regards to where they're going to choose their residency. And in addition to that, the choice of OBGYN as their, specialty area that they are going to do their residency in is being impacted by this. So certainly, and it has clearly already impacted providers who have left these areas for places where they are feeling more comfortable that they can do what they need to do. Not to mention the fact that the burden of the transfers. So some of these situations that might involve a medical condition that is not tenable for a woman to become pregnant with, who needs an abortion, maybe made it beyond 6 weeks, is in a heartbeat bill or early termination state that bans that. And so what happens? These people are being transferred to other systems in a neighboring state that may have access to abortion. And it's overburdening those practitioners and those clinics in those states. And that's going to degrade the care that women get in those states. And one other thing that, that we didn't really talk about, but is another whole a difficult area, is what's going to happen to our maternal mortality rates when we see the impact of the decline in abortion services and the, forced pregnancy, is how many women put it, onto populations that have medical risk, that have socioeconomic risk, and are not being supported by any additional family services or other other social safety net programs, because those haven't been enacted in order to accommodate this situation. And so that's not something that anybody is recording statistics on. We'll look to the future to see how that plays out.
Let me ask you, let's look at this from a slightly different perspective. Let's look at it from the standpoint of, and I'm going to ask Jane to comment about this as well, medical liability. So to go back to that the case that we talked about a little bit, let's just say we have this woman who is, say 15 weeks pregnant. She has a miscarriage. The membranes are ruptured. She's in a state with a fetal heart law, and the practitioners are reluctant to treat her appropriately and terminate the pregnancy because she still has a fetal heartbreak. And so she either dies from the sepsis or the hemorrhage, or she spends months and weeks in the ICU and gets very sick and ends up with, $50,000 or $60,000 of medical bills because the physicians were not allowed to do what is appropriate medical treatment and were essentially forced to conduct themselves as medical malpractice. Now, I'm not sure where this could go, but it would seem to me that a plaintiff's lawyer should be able to sue someone for restricting the ability of this obstetrician to provide appropriate medical care. When I was practicing, if I took something out of the wrong side of the neck or removed the wrong leg or something like that, I would be dealing with a medical liability suit. Now, what are your thoughts about, is this something, am I just sort of whistling in the wind? It just seems to me that this is something that ought to be considered. I don't know if you could sue the legislature for making laws that force people into providing medical malpractice.
Jane, do you want to comment
Well,
first? Or you directing it at me?
Yes, I'm
Okay.
sorry. I'm gonna let
Okay,
you
that's
go
all right.
first and then ask Gene
That's
next.
all right.
He's off out in
Yeah,
the.
I mean, gosh, I mean, already, the malpractice rates for obstetricians and general surgeons are the highest of any subspecialty.
Yes,
And it varies state by state, but for an OBGYN, it's in the 50,000 to 200,000 per year rate, whereas internists are, order of magnitude lower than that, at least. So, that as another deterrent to people going into the field, I think that is a valid consideration. As far as, I think the question you were asking was, would the plaintiff be a patient who was wrongfully who was harmed, then sue the legislature for the law that tied the hands of her practitioner? I really don't know.
Yes. In fact, there are 5 women who have sued the state of Texas.
Yeah.
For similar sorts of things. I mean,
Yeah.
I don't know where this is all going, but that's it seems
I
to
think
me.
we're going to see that. We're going to see that happening, and you hate to see it happening where the physicians are being sued because they're constrained and they can't do it. But I'm sure that will happen.
Gene, what are your thoughts?
I just read an article the other day where they interviewed a plaintiff and a defense malpractice attorney, and they said it hasn't happened yet, but it was their opinion that it will happen, and that the physician and the hospital will probably be sued. Now, it's going to be extremely difficult to determine the situation because of the laws and
well, these are the gray areas that Judy is talking about.
Right.
That's the whole issue. It's so vague. The laws that were basically passed by legislators who don't understand the biology of pregnancy and all the gray areas of obstetrics.
well, I don't understand why they passed these laws and made them so punitive. I have been practicing long enough but I was actually practicing before Roe versus Wade. I think that passed in 74.
Yep.
And in the 60s, when you were in medical school, you actually got to deliver babies. And then when I was an intern, I delivered a lot of babies. I was on a rotating internship. And then when I was in the Air Force, I actually was covered for OB because they were short. And I don't remember us having problems. You couldn't do abortions in those days, but you could take care of people with who had problems, like ruptured membranes and tubal pregnancies. We never even thought about it. And this was true even in the Catholic hospitals. There was no problem with any of that.
Well, I mean, just to interject, I mean, it was a time of somewhat blissful ignorance because we didn't have the ultrasound capabilities to detect some of these things, fetal heart, until around the 80s. So, we didn't always know what was going on. Transvaginal ultrasound, it really became the diagnostic tool for ectopics when I was in training, which was in the early 80s, late 70s. So there's that. But yeah, something to come back and bite us. That now you have the information and they're gonna punish you for it.
So where do you see where do you see these? I mean, as you know, standing on the sidelines, which is where you are now. I don't know how much contact you have with the people coming out of training programs. I mean, I just can't imagine anybody is going to go into a state like that to practice, and I would assume that people are going to leave the state that are put in the terrible position of not being able to practice medicine appropriately.
Yeah, no, I absolutely think it's true. I mean, I know there are a small number of OBGYN members in PNHP, and one of the ones I know well is completing her residency in New York State. She's from either Alabama or Georgia, I can't remember. And she's, studiously avoiding any practicing in any state. She's doing a fellowship actually in oncology. And her co-residents are in the same boat. And so it's definitely going to happen that, it's going to contribute even more to maternity deserts, the whole staffing issue. And it's, I'm not hearing it talked about a whole heck of a lot. This maternal mortality got a decent amount of press, but there's so much nuance to it. And, it's not being addressed or focused on, really.
I looked up the fetal heart issue on the internet after our last program, and I was pleased to find out that both the American Medical Association and the American College of Obstetrics, Obstetricians, and Gynecologists had both made statements indicating that this quote fetal heart unquote at 6, 7, or 8 weeks of pregnancy, that fetal heart at that time in pregnancy is both medically inaccurate and misleading. I'm not sure. None of that information seems to get into the ideologic brains of the legislators who are passing these laws that indicate that if you have a fetal heart rate at 6 or 8 weeks, then you can't abort that until, as long as that which is not a heart rate, it's just an image. Right. What I don't even know what do you see on an ultrasound at 6 weeks that these people are calling a fetal heart rate?
You see a little flicker, and you see it right in the middle of the fetal pole. You have a crown rump length measurement, and about halfway up, you'll see a little flicker there that indicates the electrical activity as the conduction system is being formed. But it is always it's I don't know how to put it, but it's such a milestone in an extremely desired pregnancy in an infertility population, which is where I spent my life. The ability to visualize that for the patient takes on a great deal of emotional significance. And the ultrasound is probably somewhat overused throughout pregnancy in situations where there's great commercial insurance coverage, but it's something that people are so interested in focusing on, and it allows the pro-life community to use it as another emotional manipulation tactic to convince women, as well as the population at large, that this is a situation of the beating heart, and it just has all this other significance that they can use to plead their case. And I don't know, that's how I have come to look at it. And it's completely beside the point. I mean, it's absolutely beside the point, because abortion is a healthcare constituent, and it needs to be addressed for lots of different reasons, and people need to be trained to know how to do it safely. And it will continue to be a need, as long as we're reproducing.
Well, let me ask you about something that's way over my head, but I've read a few things about the implications of this Dobbs decision about Roe involving infertility and in vitro fertilization, that there apparently is some spin-offs
Yeah,
in that aspect. Could you explain to us what?
yeah.
I totally understand that. So,
Well, not only do pro-life people want to focus on the heartbeat as this signifier of human life, they're equally happy to focus on fertilization as the event, fertilization of the egg by the sperm as the event that that starts a human life going. And if you want to talk about a ball of cells, that's really two of them, two cells right then. And in some states, the idea of these personhood bills is potentially being applied to embryos. And even in the pre-Dobbs decision landscape, in a state of Pennsylvania where we have a relatively unrestricted abortion access, we do have an Abortion Control Act that was, what the pro-life, or whoever you want to blame it on, people were able to craft, that requires all practitioners to be registered who do abortions. Every abortion has to be counted and reported to the state. And not only that, every embryo that gets discarded in an IVF practice has to be reported. So every quarter in my practice, we would report the number of embryos that we discarded. And, we often would discard embryos that didn't survive beyond the third day, or, stop developing in the lab. And, patients have the option to freeze embryos if they meet certain criteria and they can survive a freeze-thaw process. And, we would only freeze the embryos that had good potential, because we now know from even doing genetic testing on embryos that over half of them contain lethal chromosomal malformations that wouldn't make them compatible with life. So, meanwhile, for years, we're sending this data into Harrisburg, our state capital, and I'm 100% convinced that nobody's looking at it, and nobody is, nobody's acting on it. It's just another make work sort of thing. So that's a really trivial way of looking at it. But there are some states in which the question has been raised as to whether IVF would even be legal because of the manipulation of this embryo that is going on. So far that hasn't happened, and IVF practices have functioned without any sort of legislative oversight. Actually, in Europe and other developed countries, there's quite a lot more oversight placed on IVF practices. They don't allow donor eggs in the UK. There are lots of other restrictions. So it stands to reason that some restrictions will be coming.
Thank you, Doctors Judy Albert, Mike Flynn, and Jean Shively. And another reminder to listeners to join us Sunday, July 30th, 2 p.m. at the main branch Louisville Library for our celebration of Medicare's 58th birthday. We'll have the free showing of the PBS documentary, The Power to Heal, Civil Rights, Medicare, and the Struggle to Transform America's Healthcare System. And we need to finish the job. End the privatization of Medicare and the VA healthcare system, and expand and improve Medicare to everyone in our country. More information is available at our website, kyhealthcare.org. That's kyhealthcare.org. Kentuckians for Single Payer Healthcare has Facebook, Instagram, and Twitter accounts. You can check those out as well. And you can contact our chairperson, Kay Tillo, at nursenpo@aol.com. nursenpo@aol.com. Kay is always very happy to share information about the group and how folks can learn more about how to become involved. For Single Payer Radio, I'm Mark McKinley. Thanks for listening.
So I'm a nursing major, and I've seen healthcare from multiple sides, and it's a lot more expensive to come in to an emergency room and be treated for exacerbation of like a lung disease or a kidney disease, when that could have been prevented a long time ago if you had been going to your clinic normally. But some people, if they don't have health insurance, they can't do that. So it's really important to reach out and try to get basic forms of healthcare for people that may not be able to pursue it themselves. So you have to extend your reach.
Very good. Thank you very much.
Oh, I'm Sarah, and I think that single-payer healthcare should be in the U.S. because it works really well in other countries, and I believe that healthcare is like a right, not a privilege, and everyone should have access to healthcare, especially in a really advanced country like the U.S.
Good deal. Thank you, Sarah. Thanks. Perfect. Okay. Thanks, Angela. And why you support a single-payer system?
Yeah, my name is Frank Schwartz, and I reside in Louisville. And I remember Truman wanted, our country to have a single-payer health system, and we're still working on it. And it's as imperative today as it was then. Matter of fact, it's more imperative. There's a lot of money in healthcare, but it's going to the wrong places. So yes, Frank Schwartz supports single-payer.
Good deal. Thank you very much, Frank.